So I'm going to start by asking you guys, what do you understand by intestinal obstruction? I said today's lecture is going to be more of interaction than more of one-way delivery. So have you heard the term intestinal obstruction before?
Yes.
Okay, what do you think it is?
Obstruction of the free flow, the movement of the content of the intestine.
Okay, yeah, is defined as a halt in the flow of intestinal content. You are right.
Yes.
Intestinal obstruction is one question that you will likely see in your exam. However, it may not come straight for intestinal obstruction, it may come in different forms. But I can guarantee you that if you get 10 surgery questions, at least one will be in form of intestinal obstruction or acute abdomen. So one of those two most likely will come outside because it's a common surgical condition, especially it's a common surgical condition. Then even in sub-Saharan Africa, it's also very common. So you are more likely going to see question on this condition in your exam. And again, your exam is such that they will set questions based on the fact that these diseases are common. I don't know what's happening to my. Okay, so by definition, intestinal obstruction is defined as a halt in the flow of intestinal content. Now, there are two types of intestinal obstruction. We have the dynamic intestinal obstruction and the adynamic intestinal obstruction. Now, for dynamic intestinal obstruction, what it simply means is that there's a physical halt in the flow of intestinal content, usually caused by a physical obstruction. Why for adynamic intestinal obstruction is that there's a halt in intestinal content flow, but this halt is not caused by a physical factor. It can be caused by a chemical factor, it can be caused by a pathological factor, but there's no identifiable physical factor to the cause. Having said that, dynamic intestinal obstruction commonly is where the surgeons are interested in, because for surgery you have to identify the cause and go and get it out or adjust it manually. That's where the surgeon comes in, or via other means. For dynamic intestinal obstruction, the cause, like I said, is not a physical obstruction. It can be from medical and even metabolic causes. Hence, for the surgeon, we don't really focus on the adynamic part of intestinal obstruction. And the other name for dynamic intestinal obstruction is called paralytic ileus. That's the other term for it, paralytic ileus. Now, for paralytic ileus, common cause we have electrolyte derangement such as hypokalemia. You get some of the common causes.
That is for the adynamic.
Yeah, for the dynamic, hypokalemia can cause it.
Okay, hypokalemia. So for the dynamic, that's the mechanical. There will be a mechanical obstruction.
Yes, that's one that we surgeons are interested in. That's where. Sorry.
Okay. Like what called the mechanical obstruction? Like all those worms worms, right?
Yes, you're right.
Okay.
These are things that can cause. So for us surgeons, it's the dynamic one we are interested in. For the dynamic, we are not really particularly interested. But it's good you also know it that the dynamic paralytic ileus, common cause we have hypokalemia who cause it. So once you see a dynamic intestinal obstruction, then you want to make a diagnosis of a dynamic intestinal obstruction, then you have to find the non-surgical cause, such as hypokalemia. Sometimes it won't be blood accumulating in the abdomen and then causing ileus. That's for a dynamic. However, our discussion will be focused on the dynamic intestinal obstruction because that is what we as surgeons are interested in. Then how do you tear both of them apart, the dynamic and adynamic? Commonly, I'll give you one. We'll talk about the features of dynamic eventually, but one thing that tears them apart commonly is the vowel sound. For dynamic intestinal obstruction, there will usually be no vowel sound when you place your stethoscope. For the dynamic intestinal obstruction, you usually have hyperactive vowel sound. Vowel sound is usually within the range of 3 and 5 per minute. So once you have vowel sound more than 5 per minute, it's called hyperactive. So once you have vowel sound a range of 6, 5, 6, 7, 8, 9, 10 per minute, then you know you are dealing with dynamic intestinal obstruction. For the dynamic, once you have vowel sound of 1, no vowel sound 1, then you are dealing with dynamic intestinal obstruction. That's one physical sign you can use to tear them apart. Another is via investigation, where if you put a probe, you see evidence of peristalsis. Sometimes you put an ultrasound probe, you see evidence of peristalsis in the dynamic intestinal obstruction. However, for the dynamic, you will not see any peristalsis. That's another means to tear them apart again. Then, of course, the etiology. Once you take a history, a way to identify the cause, and the cause can tell you that this is dynamic and this is adynamic. Having said that, dynamic intestinal obstruction can also progress eventually to adynamic at a decompensated state. But then, most times you would have caused them before they get to that state. So I'm not going to dwell on that because for your exam, they're not going to dwell on the decompensated state. They're only going to dwell on the classical feature of intestinal obstruction for dynamic and adynamic. Having said that, some of the causes of intestinal obstruction. Now, this for the purpose of Viva, anytime they ask you cause of something in surgery, right? And then you picture it, is it a hollow viscous? If it's a hollow viscous, you can classify them into 3 categories and then you can fix the possible causes inside. Etiology is not something you cram, you picture it. Now, for anything that has that is hollow viscous, anything that has lumen inside, you can classify the cause either intraluminal, that means within the lumen, intramural, within the wall of the viscous, or extramural, outside the wall of the viscous. So anything they ask you, can you give us causes, 5 causes of, so let me say, let's say, of ureteral obstruction, ureteric obstruction rather. You know ureter is a hollow viscous. So you can classify the causes into intraluminal, intramural, extramural. We will ask you, can you give us 5 causes of obstruction to the trachea? Trachea is a hollow viscous. You can classify the causes as intraluminal, intramural, and extramural. You can also give us 5 causes of a small bowel or large bowel intestinal obstruction. You can further group them again to intraluminal, intramural, extramural. You can ask to give us causes of urethra. The first one I said was ureteral, right? You can also give us causes of urethral obstruction. You can also group them into intraluminal, intramural, and extramural. So anything that has that's a hollow viscous, you can group them into these 3, and then you will most likely and all the time you will not make mistake. So the intraluminal causes of intestinal obstruction, like you said, bag of worms like ascariasis could come together and then wrap themselves together and then form a pack or a bunch that can then obstruct flow of intestinal content. Also, two feces can become very hard, and then that hard feces can then block flow of intestinal content. Also, you see some people that have iron deficiency. Commonly, you will notice that some of them they may be eating hairs, eating leaf, eating clothes. And even sometimes some of our vegetables we eat that have high fiber content. And cellulose commonly the body does not know how to deal very well with cellulose. As such, these fibers may not be broken down. They can come together, clump together, and then form a hard mass that can block flow of intestinal content.
Oh, so doc, we are encouraged to have meals that have high fiber content, like vegetables soup, right? Vegetables, like fruits, right? Fruit.
Yeah.
Okay.
Yes, we're encouraged to do that, but sometimes it can also give this problem, and that's where this bezoars comes in. I'm trying to explain what bezoars means. Bezoars simply means foreign bodies such as fibers, clots, among others that clogs together, even hair. That's for some instance, for some weird instance, some people start eating their hair. This these substances are not well digested by the intestine, and then they clog together. They can obstruct the intestinal lumen. They also gallstones sometimes when it's big. Sometimes they find their way. How they find their way, I don't want to go into that because that would be diversionary. But sometimes the gallstone may be too big, and then they may find their way into the intestine directly, and then it can then cause obstruction. Commonly, how they do that is that when the gallstone becomes too big, it remains in the pouch of the gallbladder. That exactly and can then start exerting the pressure on the colon, especially the transverse colon. It has sometimes it may come in contact with the gallbladder, actually the hepatic part of the transverse colon. So that gallbladder, the gallstone in the gallbladder, may be exerting a pressure effect on that hepatic part of the transverse colon that can cause pressure necrosis, for which there will not be communication between the gallbladder and then the transverse colon from where the gallstone can come in. Sometimes it may not even be the transverse colon. That this same phenomenon may also occur in the duodenum and the gallstone. That large amount of gallstone could just pass into the intestine and then cause intestinal obstruction. So that's how gallstone can cause intestinal obstruction. And then classically, they'll tell you this is a gallstone ileus. That term is a misnomer because it's not actually an ileus. Question have come out like that before, especially if you are preparing for foreign exams also too, where they will give you a story of someone that has right hypochondrial pain, then they will now show you an X-ray, you see an opacification or a gallstone opacification around perhaps anywhere in the gut, and then they'll tell you what's the diagnosis, and you see gallstone ileus. It's a misnomer because commonly what normally will happen is that when there's an obstruction, you have usually a dynamic intestinal obstruction, so it's not usually an ileus. Am I communicating?
Yes.
Okay.
So it's not even an ileus. It's what?
It's called gallstone ileus, but that term is a misnomer.
Okay, gallstone ileus. Okay.
It's a misnomer.
Hmm.
So intramural causes, which means causes within the wall of the gut, could include congenital causes, whereby the gut is not well formed. You have intestinal atresia, like jejunal atresia. Atresia simply means organ that is not formed or inappropriate. So atresia simply means organ that is not formed or not properly well formed. So instances, you could see that it can occur in the duodenum or in the jejunum. Commonly, you can also see it in the ileum. So when this occurs, the patient will be born with intestinal obstruction. Also, Hirschsprung disease is another congenital condition that can cause intestinal obstruction.
The agenesis, agenesis, that means it was not formed at all.
Agenesis means it wasn't formed at all. Why
Atresia
means it was
not
formed,
properly formed.
but poorly formed.
Yes.
Yet, now for Hirschsprung disease.
Sorry, this Hirschsprung, I thought Hirschsprung was more of, due to paralytic ileus.
Sorry?
No.
I thought Hirschsprung disease was due to paralytic ileus.
No,
absence of parasympathetic ganglion.
Yes, Hirschsprung disease comes out a lot in exams. It has been since medical school. You see the even postgraduate. Now it's good.
Yes, I'm asking. I thought it was classified under
No.
dynamic.
No, Hirschsprung disease is dynamic. Why it's dynamic is that now the problem, like I told you, dynamic intestinal obstruction, there's no mechanical problem. It is a functional problem. Either there's like electrolyte derangement, like potassium that is low, calcium that is high, or there was a blood clot. Someone operated the patient and then there was bleeding, and patient did not control, or the doctor controlled the bleeding intra-op, but he didn't clean up the blood completely. That blood will not start exerting pressure on the intestine and then collapsing it. Yes. So all these are dynamic. But for Hirschsprung disease, the problem in Hirschsprung disease is that there's normally the intestine has, like I said, has neurons within the wall of the intestine. There are about 3 layers of neurons. We have the one in the mucosa called the Henle's neuron. We have the one in the submucosa called the Meissner's plexus. Then we have one in the muscle layer called the muscular layer called the Urbach plexus. Right? So in Hirschsprung disease, these 3 plexuses are absent in a segment of the colon or sometimes the entire colon. So with that absence of those neurons yet now causes a mechanical disadvantage, whereby the part that has the neuron will be having peristalsis. When it gets to this part that doesn't have neuron, there will be no peristalsis. So that part that has the Hirschsprung disease is now causing a mechanical defect. So hence, Hirschsprung disease is amenable to surgery. You have to go and excise that part of the intestine out of it and reconnect the parts that has the neurons. That's why Hirschsprung disease falls into dynamic and not adynamic.
Okay. Doc, sorry, please. Sorry. Could you please name the plexus again? The neurons in the mucosa.
Okay, there are 3 plexuses, but I think I should just mention there are 3. We have the Henle's plexuses. That's located in the mucosa. Obviously,
spell, please. Please spell.
Loop of Henle in the nephron, right? That's the Henle, Henle's plexus.
Okay, Henle's plexus.
Yeah. Then we have the Meissner's plexus found in the submucosal layer. I have the Urbach's plexus found in the muscular layer. So the problem is
please spell the last one.
Okay, Aubaeuch.
Okay, Aubaeuch.
Yeah, Aubaeuch. Yeah, that's the Urbach's plexus. So in Hirschsprung disease, these plexuses are deficient, and deficiency can be partial. That means it may just be a segment of the colon, or sometimes maybe the entire colon sometimes. Yeah, but most times it's usually a part of the segment, and that part of the segment, so that part of the colon then becomes the physical defects that can be corrected by surgery. That's why Hirschsprung disease falls into dynamic. In adynamic, commonly most times usually a global problem. For the paralytic, usually a global intestinal absence of movement. Are we communicating?
Yes.
Yeah. So like I said, these are congenital causes. Intramural causes can include tumors, or the gastric tumor, Sorry, small bowel tumor, large bowel tumors that you know of. I may not want to discuss them. We have Crohn's disease also too, tuberculosis, TB can also cause dynamic intestinal obstruction. How TB does that, it causes strictures, and that strictures becomes the factor that's not obstructing, that's not causing the obstruction. And that's how Crohn's disease and ulcerative colitis also cause intestinal obstruction. They cause stricture formation, and then the stricture then cause, it's not a physical factor that not causes the obstruction. Are we communicating? Are we communicating?
Yes, please.
Yes, sir.
Okay. Then extramural causes, we have things like hernias. Extramural cause means factors outside the wall of the intestine or of the hollow viscous, and this include hernia, volvulus, interception, enlarged lymph nodes, banks and adhesions, among others. So intestinal obstruction can be classified as acute, chronic. This is dynamic now. Dynamic intestinal obstruction can be classified as acute, chronic, acute on chronic, subacute. Then it can be classified as complete or incomplete. Right? For acute simply means sudden onset abdominal, sudden onset intestinal obstruction. That's acute. While for chronic, it's usually a gradual onset intestinal obstruction. Then acute on chronic simply means a gradual onset acute intestinal obstruction that suddenly becomes sudden. As the patient has been noticing the symptoms of intestinal obstruction gradually progressing. So all of a sudden, all the symptoms become elaborated within a short period of time. That becomes acute and chronic. But for acute, the symptoms occur within a period of hours to days. For chronic, they occur within weeks to months. Acute and chronic occur within weeks to months, with sudden elaboration of the symptoms. The incomplete and incomplete intestinal obstruction. What's complete simply means that there's a complete halt in flow of intestinal contents. For incomplete, there's passage of some intestinal content, commonly air, gases. So how do you differentiate complete and incomplete? For complete, the patient will not be passing gas, not be passing feces. For incomplete, the patient will be passing gas, but will not be passing feces. Are we communicating?
Yes.
Okay, so that's for that. The dynamic can also be classified based on location of the obstruction. When it is when the obstruction is at the level above the ampulla of Vater. The ampulla of Vater is that point whereby the pancreatic duct enters duodenum. So any obstruction above that part is called high intestinal obstruction. Any obstruction below that part is called low intestinal obstruction. It can also be classified based on the anatomic involvement of the bowel, where we will see small bowel, such as duodenum and jejunum. It could be large bowel, such as the colon, the sigmoid, and the rectum. I think I may jump this. This try to explain how the symptoms generate. I think I may jump this because I don't think if I start going through this information, I will maybe explain too much details that you may need here for your exam. So now there are 4 cardinal signs that patient with intestinal obstruction present with. And the 4 cardinal signs that you must know them. They are vomiting, abdominal pain, abdominal distension, and constipation. Those are the 4 signs. Signs are things you elicit, right? So that's signs. Those are the 4 signs that patient with intestinal obstruction present with. I come again. vomiting, abdominal pain, abdominal distension, and constipation. Now, again, let's go back. We said they are high intestinal obstruction and low intestinal obstruction. Now, these 4 cardinal symptoms we talk about, so they from this first symptom, you can tell whether it's high or it is low. Now, if the patient presents with vomiting first, right? As the first symptom, then the obstruction is high. If the patient presents with constipation as the first symptom, then the obstruction is low. Are we communicating? Are we communicating?
Okay, look, you said if the patient presents with constipation as the first symptom,
Yes.
then the obstruction is low.
Yeah. And if you present with vomiting as the first symptom, the obstruction is high.
Right.
Then if you present with pain as the first symptom, followed by central abdominal distension, right? Are you with me?
Yes.
If you can present with pain, abdominal pain, followed by central abdominal distension, right?
Yes.
Then the obstruction is at the small bowel. Are we communicating?
So at the small bowel, it presents with pain.
If you present with pain
First,
and then with central abdominal distension, the obstruction is at the small bowel. And small bowel includes the ileum, the jejunum. Am I communicating? And sometimes they will say the jejunum, but commonly we're talking about the ileum and jejunum. Am I communicating?
Yes.
If the patient presents with constipation first, and then global abdominal distension before pain, I come again. If the patient presents with constipation as the first symptoms, abdominal distension, and then pain, the problem is at the large bowel. The obstruction is at the large bowel. Are we communicating?
Yes.
If the patient presents with non-bilous projectile vomiting, are we communicating?
Yes.
Are we communicating?
Yes.
If the patient presents with non-bilous projectile vomiting, then the obstruction is likely above the ampulla of Vata. If the patient presents with non-bilous, that means non-greenish vomiting, that is projectile, then the obstruction is likely above the ampulla of Vata. Are we communicating?
Yes, sir.
Are we communicating?
Yes, sir.
Okay, so these features are very, very key in making making the right choice for your diagnosing your exam. For instance, they could tell you, they could give a clinical scenario, they will say, or they give a scenario saying patient presented with abdominal pain, abdominal distension, and then vomiting and constipation. and ask you what is this, so where it's the location of the obstruction. Small bowel, abdominal pain first, abdominal distension, constipation and vomiting, small bowel. We could ask you again, they could paint the clinical scenario. The patient was, they couldn't paint the scenario. The patient was presented with this, maybe 48-year-old man that presented with pulse rate of 120, the BP of 90/60. They paint the picture of shock for you. You have to that the patient, prior to presentation to the emergency, patient had a 1-week history of inability to defecate, abdominal distension, and then abdominal pain. They may ask you, what is your diagnosis? You will see things like sigmoid volvulus. You see things like small bowel tumor. You will see things like gastric outlet obstruction. If the first symptom was constipation, abdominal distension, then abdominal pain, then you are dealing with a large bowel disease. So you look for the option that has large bowel disease, such as, for instance, in this option, sigmoid volvulus was the answer. Are we communicating?
Hmm.
Are we communicating?
Yes, sir.
Okay. So I guess.
Please.
Sorry?
We're talking about acute obstruction. How do we classify acute constipation?
That can be complete or incomplete. Right? When it's incomplete, it means the patient is passing flatus. If it's complete, the patient is passing, it's not passing either flatus or physis. Okay, again, it can be high or it could be low based on ampulla obverta. If it's above the ampulla obverta, it's high. If it's below the ampulla obverta, it is low. Okay, but then the various part of the intestine, like I told you before, dynamic, there's a known cause that's amenable to surgery, and that's the mechanical cause. So ability to be able to identify the mechanical cause from your history and your examination is key. And that's where your question will lie. You understand? So they may give you a story and then will tell you the patient presented with constipation, abdominal distension, abdominal pain, and vomiting. What's your diagnosis? They'll put things like gastric artery obstruction, things like diverticulitis or the diverticulosis of the jejunum. They could even put iliocecal TB, and then they will not put sigmoid volvulus. Of course, the answer is sigmoid volvulus because this scenario is a large bowel obstruction. They could also tell you that the patient presented with abdominal pain and then abdominal distension. Come on, they don't want to help you. They'll tell you central abdominal distension. Then vomiting and constipation can come as the other third or fourth symptom. Where is the source of the obstruction? It's a small bowel obstruction. Small bowel obstruction will start with pain before central abdominal distension. Are we communicating? If you're not understanding, let me know. We can always come back home. So some of the causes of death from this disease is shock, dehydration, electrolyte, and now the shock is coming because as there's an obstruction, the patient is losing fluid into the peritoneal cavity, even into the gut itself. That will lead to dehydration and consequently shock. Electrolyte imbalance is coming because the patient is vomiting, and then there's patient is vomiting and it's not replacing the lost electrolyte and the fluid that that vomiting is coming. Peritonitis is coming because with this, there's translocation of bacteria from the gut into the peritoneum. Of course, with peritonitis, sepsis occur. Then respiratory failure occur because with that abdominal distension, there's splinting of the diaphragm, and that will lead to respiratory embarrassment, and then patient will die. Multi-organ failure occurs because of the shock, the dehydration, the respiratory embarrassment, the sepsis, and the electrolyte imbalance. Again, like I told you, the first signs that makes up the symptoms of abdominal intestinal obstruction, again, abdominal pain, abdominal distension, vomiting, and constipation. I've explained earlier on how you're able to make a diagnosis of the various spots where this obstruction could occur. And that's, like I told you, that's where one part of your exam lies. Such question is going to come, they're going to ask you where it's coming from. So you need to know where it's coming from. These are examination findings you see. It's then rectal, okay, fine. Then again, if investigation that you want to do for these patients to confirm your diagnosis and
no, please, the previous slide, please.
Should I?
Okay, thank you.
Do you want to explain it to you, or what do you?
No, it's okay. I just wanted to take a screenshot.
Okay. So for diagnosis, we commonly is an X-ray we do, and the X-ray is an erect and supine. Again, this can also be an exam question where they will tell you what X-ray will you do. They will put AP lateral as an option for you, just to divert your attention. The answer is erect and supine. And then where on that question comes out, usually come out from this X-ray. And the question they will ask you is, what are the features you can see? Right? For supine X-ray, what you see, you're going to see dilated bowel. Right? What is a dilated bowel? A dilated bowel is bowel in which the diameter is more than 3 cm for small bowel, and it's more than 5 cm for large bowel. Are we communicating?
Yes, please.
So these are information that you need to know.
So dilated is more than 5 cm.
For large bowel and 3 cm for small bowel. Are we communicating?
Yes.
Okay, that is for the supine X-ray. Then for the erect X-ray, what you see is multiple air fluid level. Right? What is multiple air fluid level? More than 3 air fluid level is considered as multiple air fluid level. Are we communicating?
Yes.
Okay, so if you see 3 air fluid level, it's not multiple, it's a normal X-ray. When you see 4, 5, 6, and then that's what we consider as multiple X-ray. Because 3x3, there are actually 3 places you see air on X-ray film. So those 3 places are sacrosanct. You will see them in the X-ray. So it's when it's more than those 3 that you now say it's multiple air fluid level. Another question that can come out from this place again is that they could tell you what are the features in the X-ray that can tell you that this is large bowel. What are the features that in the X-ray that can tell you that this is a jejunal obstruction? But what are the features in the X-ray that can tell you that this is an ileal obstruction? Now, for a large bowel obstruction, commonly you see that the dilatation is at the periphery, right? And you see that the margin of the bowel or at the periphery of the abdomen, following the tract of the large bowel, right? That's one. Like I said, it's more than 5 cm diameter on the X-ray film, right? That's one. Another thing you see what's called frustrations. You know, the large bowel, usually, if you look at it physically, it's like the type of game used to play this, that you roll your hand, the 2 hands in the ground to create something like almost like a circle where you can be jumping across. So that's what we call obstructions. In the X-ray, you see something like that, where you see normally there's usually what's called thinner coli, right? That thinner coli is longitudinal muscles that run across the colon, and that helps to cause intermittent constriction of the colon. And that intermittent constriction is what is seen as obstructions in the X-ray. Again, I said the dilatation will be on the periphery, then you see obstructions. That is one feature you will see. That's how you know that is large bowel obstruction. For small bowel obstruction, for what you will see for jejunal obstruction, you see what is called Kecking's ring. What is information I'm telling you, they've come out before in exams, and it's not different than
What's the spelling, please? What is spelling, please?
Kirrockking. Kecking's ring, you see it.
So you find this in a jejunum?
In jejunum, yeah. So the other name for it is called plicae secularis. PLICAE secularis. CRRCULARIS.
Please spell again. Fly.
Plicae, PLICAE.
Okay, secularis.
Yeah, that's the other name for it. But the common name for it is Kecking's ring. That's what you may see. Sometimes an examiner may just decide to use the other name for you. Get. Okay, so that's what you see on the X-ray. For the ileum, what you see is what they will tell you is characterless. It doesn't have a character, and that's the terminology you should know. Again, this information I'm telling you may come out in your OSCE. May come out and ask you what are the features you see in X-ray that tell us that this is small bowel involved in obstruction, large bowel is involved in obstruction. Those are things you see. Then, most importantly, for any of them, right, there will be no gas in the rectum. If you see rectal gas, it's either partial intestinal. If you see paucity of rectal gas and you see all these features of intestinal obstruction, then it is a partial intestinal obstruction. Are we communicating?
Yeah.
So, but in your exam, they may likely not give you partial intestinal obstruction, they'll give you complete intestinal obstruction. So you will not see gas in the rectum. So other tests you want to do to prepare the patient for electrolyte urine creatinine and the PCV. So the differential diagnosis of dynamic intestinal obstruction is adynamic intestinal obstruction, acute pancreatitis, typhoid perforation, among others. So again, question can come out from this from management again, in the sense that it can be a form of an L question. They will give a quick scenario. Then you should be able to make a diagnosis of intestinal obstruction, and then they'll ask you how they manage the patient. Now, for surgical emergencies that involves the abdomen, right? You must pass 3 tubes. The 3 tubes are NG tube, urethral catheter, and IV line. Are you communicating?
Yes, please. Okay, so to resuscitate,
you must pass.
Okay. Somebody already having intestinal obstruction.
Yeah.
So, okay.
You must pass NG tube. You must set a line, an IV access, and then you pass urethral catheter. Then for your OSCE, further on, you have to explain why you do this. You pass NG tube 1 to decongest the bowel. This will help to reduce splinting of the diaphragm.
Okay, to decongest the bowel.
Yes. But we don't use the word decongest, we use the word decompress. That's what we use. But I'm trying to explain to you what is done. Is to decongest. That means once you pass the NG tube, effluent in the, that have accumulated in the gut will find its way through the NG tube out. So
Yes.
by doing that, they are decompressing it. So that pressure is exactly on the diaphragm will be reduced. Are we communicating?
Yes.
Also, to the pressure that ab initio was being exerted on the wall of the intestine will also reduce. That will help healing of the intestine also too. Then you pass a urination catheter because you want to monitor urine output for this patient. This is very key to know how you hydrate the patient. Are you communicating? Are you communicating?
Yes, sir.
Then the last is you set a line to give fluid for the patient. Then you give pain medication, antibiotics for the patient. Now, for the definitive treatment, that is to resuscitate the patient. Once you've done, you pass the IV fluid, you correct the dehydration, we take samples for investigation, which include the full blood count, electrolyte, and creatinine. Whatever is the derangement from your investigation, you correct. Once you correct, you take the patient to theater and then you operate the patient. The type of operation, whatever the type of operation you do inside the theater depends on what you find inside as a cause of the intestinal obstruction. So if it is band and addition, you do what's called additionalisis. This part will not likely come out to your exam. If it is from an obstruction such as Hirschsprung disease, you do recessional anastomosis. If from a tumor, you do recessional anastomosis. Like I said, this part will not come out in your exam. If from hernia, you do heniography. What may come outside will be from the resuscitation upwards to what we have discussed. Are you communicating?
Yes, please.
So again, like I said, the definitive treatment, what you do exploratory laparotomy. And what exploratory laparotomy means is exploration in the abdomen. And that exploration will depend on what you find inside. But the terminology for that thing you do is called exploratory laparotomy. And it's called exploratory laparotomy because you don't know exactly what you're going to do. You're only going to explore. Laparotomy simply means opening to the abdomen. So exploratory laparotomy simply means exploring when you enter into the abdomen. So definitive treatment will be what you find after your exploration. When you explore, you be able to identify the cause of the obstruction. Like I said, if it's band and addition, we do additionalisis. If it is a tumor that is resectable, we do recessional anastomosis. If from a stricture, you can do recessional anastomosis, or you could do stricturoplasty. If it's from hernia, you do heniography. So I will not dwell on the definitive treatment because, like I said, the exam at your level is not going to be focused on definitive care. It's at our level that we'll focus on that. The level will focus on resuscitation and the other information we discussed. So it's good we see the information and then give it to you guys as is needed. Having said that, and that ends this lecture, intestinal obstruction. Is there any question you want to ask me so that we?
Yes, sir. So, Doc,
Okay.
so for example, where do we put hemorrhoids? Can hemorrhoids after some time lead to intestinal strangulation, obstruction, in any way, and lead to sepsis, peritonitis, sepsis, multiple organ failure, and death?
No, hemorrhoid will not cause intestinal obstruction. Hemorrhoid will cause what hemorrhoid can ever cause, right? The worst it can ever cause is that the hemorrhoid can become thrombosed. That means the blood, in hemorrhoid, what happens is that in the rectum, there's usually a loose connection of venous plexuses, sometimes arteriovenous plexuses, what they call rectal cushions. They are part of a padding system that helps to pad the rectum. There are 3 padding systems that help to pad the rectum while it performs its function. So for whatever reason, either there's a weakness in the muscle or there's increase in intrarectal pressure. That will not start forcing this rectal, will not cause a weakening in the rectal wall. That will not start causing this cushions to start pulling into the lumen of the rectum, right? And when it's pulled down, gravity will also aid it and you pull through to the anal canal and then pull out. So the worst problem that can ever occur in hemorrhoid is that those blood inside those rectal cushions can clot. And when it clots, it can then block the flow of blood from the rectal cushions. And when it blocks the flow of blood, what now happens? Blood piles up in the rectal cushion and then ischemia occurs. Normally, for ischemia not to occur, blood must be circulating. If blood does not circulate, it means that no oxygenated blood occurs, gets to that tissue, and then ischemia occurs, right?
Yes.
Now, when it gets clots, when that clot occurs and block the circulation in that rectal cushion, it then leads to pain, severe pain, and that's the pain. If someone that has hemorrhoid, when they have pain, it simply means that there's thrombosis of the hemorrhoid. That's what it means. So then, if that ischemia occurs, right, and it's not it's not medically dealt with, the ischemia can lead to erosion of the rectal cushion, and that will not expose the rectal lining to. Normally, the rectal lining helps to prevent infection, as in bacteria in the colon, from getting into the circulation. But once it's breached, there's free flow of rectal organisms into the circulation, and the worst patient can ever have is sepsis and not obstruction.
Okay.
Yes,
but sepsis will lead to death. It will lead to death.
Yes, it can lead to death. It can go to the sepsis and then patient can die. Yeah. So that's the worst. They cannot have obstruction. The worst they can ever get is sepsis.
Sepsis. Okay. Thank you.
Okay, so is there any question going to ask again? Okay, so maybe I will have to. Okay.
Thank you very much.
Okay, I'll have to end this recording, but I think I want us to have some few conversation before I put this lecture to an end today. Meanwhile, there may likely be ophthalmology lecture by 7 o'clock anyway. He was supposed to come by 5, but we spoke, and then he has a case in theater. So that case finished before 7, or to be 7, we'll have it by 7. What happens maybe shifted on that day. What I want to say is that, first of all, let me first start by saying that let me start on the positive by commending some of you, especially Justice. Sometimes Cynthia, well, there's Cynthia sometimes too. I know she's busy, so I may not want to. I think she's trying because she's busy. But then again, sorry, I think I need to.